Okay, so our last group of diuretics that I will be discussing is the osmotic diuretic. The prototypical drug that I'll be using, I'll be talking about is mannitol. So this is the drug that we are going to discuss. So unlike other diuretics that I have talked about, this mannitol does not block any sodium channel, does not affect any enzyme, does not block or inhibit any symphoter. So they are not affecting any biological membranes. But what this drug is doing is that when you give this drug, the drug is freely floated. And when the drug is floated, it undergoes minimal reabsorption. So the drug is not reabsorbed. And mannitol contains certain solutes inside. So when you give mannitol, the drug is freely floated and it remains along the length of the nephron, mostly at the plasma tubule, but it can also remain along the length of the nephron. So when mannitol is administered, what does it do? Mannitol will be freely floated. And when mannitol is freely floated, they undergo minimal reabsorption. That means that they are not reabsorbed. And mannitol will not go and block any sodium channel or any transporters or any enzyme. So they remain along the length of the nephrons and they causes their pharmacological activities. All right. So the class of the drug is called osmotic diuretics. So as we all know, what is osmosis? Osmosis was the movement of solute from a region of lower concentration to a region of a higher concentration through a semi-permeable membrane. So when we are going to use mannitol, we are going to move solute from a region of lower concentration to a region of higher concentration. So when you administer mannitol will be highly concentrated within the nephron. So it creates that different solute gradient. So solute will want to move from a region of lower concentration, which will be in the blood, to a region of higher concentration, which will be where the filtrates are or the nephrons, and that causes us to lose fluid. The amount of diuresis that a person produces is similar to the concentration of mannitol that is present. That means that if you have a higher concentration of mannitol present, then the amount of diuresis that a person will produce will be high. If you have lesser concentration of the mannitol present, then the amount of diuresis that will produce will be low. So that is mannitol. Alright, so as I said, when you give mannitol, they are freely floated, then they remain along the length of the nephron, and it increases the solute concentration within the nephron. And once the solute concentrations are increased, now water will be drawn from a region of low solute concentration to a region of higher solute concentration. This time around, which is within the nephrons, and it works very much. Let's look at the uses of mannitol. We can use mannitol for the treatment of what we call increased intracranial pressure. When probably due to an accident or due to some head injury, someone is having maybe buildup of fluid. When someone is having buildup of fluid within the cranium, causing an increase in intracranial pressure, one of the diuretics that we can use for the management of this condition is mannitol. When you give mannitol through IV, the drug goes to circulation, some remains within the vessels, within the brain, and that causes difference in osmotic gradient, because the drug will be highly concentrated within the vessels in the brain, and that will cause fluid to shift from the brain to the blood vessels, and thereby we lose the fluid. So we can use mannitol to manage increased intracranial pressure. We can also use mannitol to reduce increased intraocular pressure, which might be due to head injury or increased intracranial pressure. So we can use this drug to also manage an increase in intraocular pressure. So when we give this drug, we can reduce intracranial pressure then we can also reduce intraocular pressure. The next thing that I'll be talking about is that we can use monitor for the management or prophylaxis for renal failure. If someone's kidney is failing and at a point in time the person is not producing urine, if you're not producing urine, we call it anuria. If you're not producing urine, we can use monitor to help a person to produce urine. If you're not producing urine, it might be causing a lot of injury to your kidney. Your kidney can fail and will die. So if someone is having some form of renal failure and their urine production is going low or they are not even producing urine at all, what we can give is that we can give monitor. And when we give monitor, what happens? Okay, let me tell you. So under under certain conditions, such as maybe dehydration or hypovolemic shock or hypotension, what happens is that the amount of blood flow to the kidney reduces. And if the amount of blood flow that goes to the kidney reduces, that affects the filtrate volume that gets to the kidney. And if the filtrate volume also goes down, what is going to happen? Because of low blood flow to the kidney and because of low filtrate volume, what the body will do is that the body will try and reabsorb almost all the content or almost all the electrolytes that were present at that moment. So if, let's say, at this point in time, the filtrate coming in is less, and we have sodium, we have chloride, maybe we have, let's assume we have calcium over here. Because of the low blood volume or low filtrate that gets to the kidney, what the body will do is that the body will reabsorb almost all the electrolytes. And if the body is reabsorbing all these electrolytes, then what will happen? Water will follow. And if water follows, because they are absorbing almost all the electrolytes, then you are going to reabsorb almost all the water. And if you have reabsorbed almost all the water, what you are going to do is that at a point in time, the body or the person will not be able to produce urine. So as a means of trying to reverse that effect, we can give the osmotic diuretic. So when you give the drug, I said this drug, we can give this drug mostly by IV. So when you give the drug by IV, what is going to happen is that because this drug is a water-soluble drug do not cross blood or do not cross the cell membrane. So do you get it? And because they are not crossing the cell membrane, they do not be reabsorbed. So that means that they are going to stay within the nephron. So if the monitor stays within the nephron, what happens is that it increases the solute concentration within the nephron. Because the monitor itself contains solute. So the solute concentration within the nephron increases. And once the solute concentration increases, what is going to happen is that it is also going to draw water to it. Because the monitor itself is not reabsorbed. So it's going to remain within the length of the nephron. And that will also draw water to it. And once we have water being drawn to where the solute concentration is high, so water will be moving from the interstitial spaces into the lumen of the nephron, and that will increase maybe water reabsorption. And if water absorption, and if water is absorbed into the nephron, then at a point in time we are going to lose the person will be able to pass out urine. So monitor will increase the solute concentration within the nephron, and that will draw water to it, and that will help a person who is unable to produce urine to be able to produce urine. So we can use monitor as a prophylaxis for renal failure, and this is how monitor is used as prophylaxis for renal failure. We have talked about the uses. So the main use of monitor is for maybe management of increased intracranial pressure. We can use this agent to also manage increased intraocular pressure. Then we can use this agent for prophylaxis for the management of renal failure. One major side effect of monitor is sometimes edema. Is edema. As I said, the amount of diuresis produced is similar to the concentration of monitor in the body. And most of the time, if you are going to administer monitor, you have to administer it through IV and go slowly. Because if you increase the flow rate the quantity of mannitol that gets into the body, the concentration that goes into the body will also, the person will also pass out what similar what urine. Are you okay? So when you are going to administer mannitol by IV fluid, you have to try as much as possible to run it under low flow rate. So with that said and done, that is all about what the osmotic diuretic that we have mannitol as a prototype drug that we are looking at. So as a way of recapping everything that we have done, we started with the carbonic anhydrase inhibitors, where we said they are working within the proximal tubule. Then we came to talk about the loop diuretics, where we said those drugs also work within the thick ascending loop of Henle. Then we came to talk about the thiazide diuretics, where we said they are acting in the early part of the distal convoluted tubule. Then we came to talk about the potassium-sparing diuretics, where we said they are acting at the principal cell of the collecting tubules. Then now we have discussed the osmotic diuretics. So if you have any questions, drop your questions in the comment section. Let us know your questions and let us know how we will be able to help you. Thank you.